Thank you very much for joining us tonight for our next lecture series. Tonight we have RoseMarie Perez Foster chatting about understanding dementia, and she is a clinical and research psychologist who's a retired professor from CU Boulder. But her connection to the Hearts and Horses community is that this past summer she adopted Bentley. So she can also tell us a little bit about how much he's loving his new home. So I will turn it over to you.
Thank you, Emmy. Thanks very much. It's really nice to be here. I've seen one or two of your faces when I've been up to the area. Can you still hear me? Oh, okay. And I never knew Hearts and Horses existed until I saw an ad for Bentley on FaceTime, and the rest is. I adopted him over the summer, and he has been really getting himself comfortable in his new home. He is totally the boss of the other horse, whose name is Jazzy Boy, and who's not so jazzy anymore. Bentley's the jazzy one, but he's doing really well. He's put on a lot of weight. He loves going on trails, and I'm just really lucky to have him. He's really, really good. So I thank you for that. Anyway, so, I realized that doing this tonight really kind of combines for me two of the things I love most in the world, which are psychology and horses. Excuse me, equines. So this is a great experience for me. And when I found out that you all did this Writing in the Moment program, I was really, really interested and started to do, some reading on it. So I hope that at some point I'll be able to train too, to do that. Dementia is an area that I'm very interested in, especially non-medical and alternative ways of approaching a group of people who, in fact, are very, very compromised, very, very ill, and for whom there is absolutely no cure as of yet. And what it's proving to be is that it is the alternative treatments, or let's call them interventions, because they're not really treatments, as dementias from certain brain disorders will never improve, but at least there is maybe sometimes a few minutes of an increased quality of life. And what the great news is that when you look at some of the research that's starting to happen in this area, what you're doing is really working, because in the beginning, what was shown is that people were enlivened, clients were enlivened during the actual interventions and during the activities, but there was no information about what happened later. But some papers are starting to come out where there is arousal in the facility at the home and residence where they live, where they're showing a bit more expression and pleasure, where they're showing a little bit more of orientation. That is huge. And all you need to do is get larger samples to show what's really happening. Because if these changes are lasting, that's extremely powerful. So starting on a very positive note, what you're doing really works. All right, let's get into the nitty-gritty of this, though, the stuff that we are still vague and don't have so many controls over. So I first want to say, if there's anything I want you to carry away with you tonight, is that dementia is an illness. Dementia is a set of symptoms that comes from brain illnesses. And that as people age, however, who do not have dementia, they also experience certain kinds of cognitive thought changes, thinking changes. I know we all joke about, I forgot this, I'm having a senior moment, but there is stuff that happens to us as part of normal aging. And some of the things are, subtle forgetfulness, forgetting you're gonna have coffee with somebody, or misplacing objects, the famous "where's my iPhone" thing. Sometimes people have difficulty recalling words. What's the name of that thing, that gadget that you use to fix that so-and-so? Oh yeah, screwdriver, As people get older, they have, and you probably know this from, parents and people in your family, they have a little more trouble multitasking, which is, people are used to doing at least 100 things at once. But in a way, as you get older, it's hard to multitask. Again, normal stuff. Sometimes people, as they get older, have a little trouble processing things. They get it, they understand what you're saying, but it may have to be repeated an extra time. There's some decline in reasoning as people get older into their 80s. But on a positive note, there are actually cognitive things that improve with age. I was shocked when I recently saw that, which is that our vocabulary actually is very resilient to changing over time, and that it becomes enhanced and larger. And it seems to be pretty tough, which is that words somehow stay in there. So what I want to say in summary is that this is all normal stuff. It ain't dementia in the least, okay? So these are normal aging changes, okay? So let's go to the next spot. All right, so what is dementia? Okay, dementia per se is not a disease state. It's actually a descriptive state that's an overall term to describe a cluster of symptoms. And these symptoms come from brain disorders that we'll talk about. You've probably heard quite a few of them already. But what dementia is a cluster of symptoms in which people have a lot of difficulties with memory, with language, forgetting words in a very significant way, problem solving, and other thinking and cognitive skills that actually make it hard for them to get along in everyday life. Something I want to emphasize too is that dementia is a slowly unrolling process that's considered in a person. A physician would only consider dementia if a reliable witness, like, a partner, a spouse, a roommate, whatever, can describe that the person has been having some trouble with their thinking for about a good 6 to 12 months. It's not something that happens just overnight. So it's only considered if the complaints are of a longish duration. Because, just to mention this and to make the distinction, there are multiple other conditions that actually will have impacts and can have impacts on your cognition, make your cognition decline, that are not dementia. And usually these come on in a very acute way, especially in older people. Like, for instance, sometimes it's a medication reaction that makes you fuzzy, like a sleeping pill or something where you're zonked the next day, or a cardiac event, a heart attack, where the brain isn't getting enough oxygen and memory goes and there's confusion. Depression. We know older people who are depressed. Well, did you know that sometimes depression causes confusion and disorientation? And it's actually not so difficult to treat. All of a sudden, you treat the depression and the person can, do their volunteer job again, okay, which is pretty powerful. We can talk about that later if you want. And other things like kidney disease will cause confusion. But these are acute, very, very temporary states that come on suddenly and are not dementia. All right, so let's go to the next. So what are the causes of dementia? Okay, first I want you to picture this in a way, sort of have a graphic example of what the brain looks like. So the healthy brain, did you know, has about 100 billion cells. They call brain cells neurons. And neurons are very unique cells because they have like this round center, but they have these spikes, these tendrils, these long connections that allow them to connect with other neurons. And when the brain is connected, which is when it's in its whole piece, all right, there are thought to be about 100 trillion connections in the healthy brain, okay? All right, so these networks, these connections form, you could say, neuronal networks, all right, that manage all of our functions, our thinking, our feeling, our bodily functions, speaking, walking, eating, breathing, digesting, the whole bit about being human. I don't know if it has a soul, but at least the functions in the body and thinking, all right? But what brain disease does, all right, such as Alzheimer's and other dementias, is that they progressively begin to actually destroy these neuronal networks. And what they do is compromise the person's thinking, cognition, and bodily function in a mild way, in a moderate way, or sometimes in a really severe way, all right? Okay, so I wanted you to have that picture of the brain and its connections and its healthy networks. But here's what happens with certain brain diseases, okay? And so here are the diseases that cause this dementia state. The first one is one that you are very familiar with, that we all are, unfortunately, and that is Alzheimer's disease. It's the most common cause of dementia, and it accounts for 60 to 80% of the cases in the United States. The numbers are a little bit different internationally. Every country in a way has their own prevalence of certain diseases, but in our country, think about this, up to 80% of the cases of dementia are from Alzheimer's. And in this disease, the physical brain starts to deteriorate way, way before you even see the hint of a symptom, which is they think that 20 years or more, the Alzheimer's process is in the works, is in the makes, and it is slowly making networks disappear in the brain. Eventually, a good 20 years or more later, is when you begin to see the hint of symptoms like memory loss and trouble with language. And basically what happens is that when areas of the brain get destroyed, the functions that are managed by that network of neurons just become compromised. Okay, so this disease, unfortunately, is progressive and deteriorative. In other words, it never gets better. It'll get worse, so that many other areas of the brain become compromised, so that walking and swallowing eventually become all affected. And we all sadly know, and maybe we know this in our families, that bed care is needed, that people will need round-the-clock care will be required. And the disease ultimately is fatal. And interestingly, what happens is that people often expire, often die from an asphyxia, from swallowing, from not being able to pass something in the throat. And they basically don't have any breath and die, all right? So just to talk a tiny little bit about what these pathological things are that form in the brain of the Alzheimer's patient, is that there are these plaques, these amyloid plaques that actually begin to develop, those 20 years or more, that begin to develop outside these neurons. And also one of the most recent findings after the findings of the plaques is that within the neurons themselves, there is a accumulation of tau, T-A-U, a tau protein that actually forms tangles within the neuron and eventually kills it. Okay, so it's a violent kind of disease, Okay, so let's move on to, so that is the most common disease of the brain that yields dementia and how the person functions. The next one, which you probably have heard, is vascular dementia, and that's the second most common cause of it. And the areas are destroyed by strokes, either a single stroke or a series of maybe smaller strokes. And there are different kinds, a burst, hemorrhagic or ischemic. One of them, you can get a stroke from an actual burst blood vessel in the brain, or from a blockage in which a small, let's say, blood clot maybe travels or even stays there and blocks blood flow to that part of the brain. In any case, what happens is the same thing. Blood is blocked to those neurons who don't get the oxygen, and those neurons actually die, all right? And you can have what they call a cerebrovascular incident, a stroke, in any part of the brain, which is why often when we find out that someone has had a stroke, you know, they're kind of fuzzy, they've lost some memory, they've lost some language. Um, their facial features are, they can't move them in the same way. They have trouble walking using a left arm or a right arm, etc. And these are representative of the different spots in the brain that have been deprived of oxygen by a stroke. Okay. All right. So the next kind of disease that causes dementia, and there's only one or two more, is something called Lewy body disease. It's less common, but it's very much defined. And this is where clumps of abnormal protein, and interestingly, a different kind of protein. So this whole business is a very, very complex thing. They're called Lewy bodies. They're very small, and they're actually found around and between the neurons. And the symptoms are similar to Alzheimer's, but in the early phases, you see other things, like people are sleepy, they become sleep disturbances, but also there are visual hallucinations and visual spatial impairments. And that is very telling of the diagnosis of Lewy body disease, which is the visual hallucinations, which are very, very graphic. People see things, they see objects, they see people. It's very interesting. All right, and the last kind of brain disease that I'll talk about is something called frontotemporal dementia. And you might have heard about this because there's something extremely impressive about it, which is that you see it happen to younger people, to people in middle age. And this is another degenerative disease of the brain that affects the frontotemporal area here, about here. It starts earlier, as I said, and the early symptoms are different. It's not a memory thing early on, but it is extreme changes and fluctuations in personality and behavior. So that's something that's considered, you know, in terms of doing a differential diagnosis, is a possible psychosis. Is this an acute drug reaction that the person is behaving and not themselves? The language becomes impaired, but interestingly, the memory gets spared until way later in the disease. So it's a very interesting kind of presentation. Okay, and then you also have dementia that comes from, unfortunately, multiple of these diseases. So that, let's say a person has Alzheimer's and then they get a stroke, and then they are really, really compromised. Okay, now I realize that these severe situations that I'm talking about, the worst of the symptoms, aren't the folks that you see. You know, we'll get to that. But just to understand what the progression is of these disorders is just, it's just so impressive, you know? So here are some basic facts about Alzheimer's disease, which I'll kind of talk about predominantly because it's mostly what we see. So Alzheimer's disease and general dementia. So when I did, currently 5.8 million people in the United States are diagnosed with Alzheimer's. That's an amazing number. Interestingly, the last time I did a talk on this was, you know, I don't know, maybe about 2 years ago, and I used some literature, you know, that I had and etc. And at that point, the most recent statistics were, guess what, 5.4 million. And this 5.8 comes out of the 2020 statistics from the NIH. So it is really going up, and the number is projected to be increasing rapidly for the coming years, which is pretty scary, okay? Now, one reason for that, a big reason for that, is that people are living longer, okay? So the longer people live is that they're staying around to be diagnosed with this disease, okay? So that's a big reason why, you know, we're seeing the increasing numbers, okay, because more older people are around. But the question always is, so what else is it? Is it our environment? Is it what we eat and what we breathe? You know, we're very conscious of all of these things, maybe a little bit more than other people in other parts of the United States. I'm from the East Coast, from New York, and I'm so much more conscious about what I breathe and what I eat and the toxicity in the air. So, like, what the heck is it, you know? Maybe longevity is not the only thing. So The prevalence of the disease increases with age, and I'll show you some numbers in a minute. The older you are, the more the higher the prevalence of the disease in that age group, okay? Now, I want you to, I maybe should have underlined the next one a little bit more, but there are approximately 200,000 people who get Alzheimer's who are under the age of 65. So it's called younger onset Alzheimer's. And that's always very impressive. You know, a diagnosis of Alzheimer's at age 50. I mean, you know, holy cow. It's a tremendous surprise, but it's also, think of this, it's a giant burden socioeconomically to the family, because under 65, these folks aren't eligible for Medicare. So what you're talking about is people having to use their regular insurance, which is not Alzheimer's friendly, okay? And their their home savings. So it's really quite a complicated situation in this early onset Alzheimer's. And a shocking figure is that Alzheimer's patients make up 50% of all nursing home beds. Isn't that something? It's really impressive. Okay, so let's move on now. So what are the risk factors? You know, I read this stuff and my mind is ticking, you know, who in my family, what are the risk factors for this? Well, age is a big risk factor for it. So look, here are these numbers. So between 65 and 74, only 3% of these are all American statistics, American people have Alzheimer's. But look at how these numbers rise. From 75 to 84, we're talking 17% of people in the United States in that age cohort have it. And look at this, 85 and over, 32% have it. That's like a third of the people in the United States who are 85 and older have Alzheimer's disease and therefore dementia because of it. All right? Another risk factor besides age, just age, basic and per se, is family history. And there's a strong genetic component, particularly for that thing I just mentioned before, the early onset. There's a particular genetic proclivity, let's say, for early onset Alzheimer's. There is for later onset as well, but not as strong as for the early. And then gender, and you know, I double check this because I was a little surprised that this was still the case, which is that it seems to be more prevalent in women. Women have a higher prevalence of Alzheimer's. Now, it is believed to be because of, again, longevity, in the sense that women live older than men. So there are more women around in those older age groups to get diagnosed with it. But they feel that the higher number in women needs to be accounted for more than longevity. They think that it's something else. So that's an interesting question. And finally, there are life exposure factors, which is that folks who've had head trauma, falling off motorcycles, falling, you know, occupationally related head trauma, car accidents, etc., seem to have a higher incidence of head trauma, of Alzheimer's later on in life. And then there are the bugaboos that we hear about every day, which are high cholesterol, diabetes, hypertension, and obesity. There seems to be a background here where these conditions render and yield a higher percentage of Alzheimer's disease in people. Okay. We have a little bit left, but shall we, Emmy, should we maybe do some questions here? Or I realize it's a lot of factoids. Maybe people have some questions. You want to do them now, or shall we wait?
Sure, we can see if there's any questions.
Any questions so far?
Actually, Emmy, I have a question.
Or comments?
Did you hear me?
Yes.
Yeah, go for it, Rich.
Okay. Now, when my Peggy was diagnosed with early onset dementia, the thing I noticed was she was becoming kind of paranoid, and I'd be accused of, certain things that I didn't do, but it was just, it seemed like all of a sudden that was happening. What classification of dementia would you consider that to be?
Do you know what kind of dementia she has?
Well, she was diagnosed with early onset
With
dementia,
early
but
onset. Okay.
but I think the frontotemporal dementia kind of best describes her situation.
Okay. All right.
But I noticed, as I said in the beginning, that she kind of got accusatory.
Yeah.
Um, and I think that's kind of typical of Alzheimer's, isn't it?
Well, you do see that. You
Hmm.
do see that. Something that I haven't gotten into is talking about the basic sort of psychological problems that can also intertwine and be what they call comorbid
Hmm.
with dementia. Okay, like
Yeah.
for instance, would you believe for folks who we see who seem apathetic and flat and as part of the dementia, they can also be suffering from depression. All
Yeah.
right. And by the way, let me say that the depression is treatable.
Hmm.
That part is treatable. It's not the
Right.
dementia. It's the what they call functional disorder. Okay. And sometimes people get extremely defensive because it's a way. In other words, no, I didn't forget to put the cup there. You did. You know that
Yeah.
kind of thing. People get extremely defensive as a way of covering up for their decline,
Hmm.
and that can become habitual. It also depends on on the household and what's going on with them,
Right.
also their own personalities. But try to think of this, try to think of your mind not being what it used to be, and you're seeing yourself decline, what that must feel like,
Hmm.
and how in a way you're trying to rationalize that you're not so different. Well, we think of it. That would make me paranoid and have a difficult time with that. And thinking that everybody was telling me that I wasn't functioning correctly, when in fact I know that I always put my dishes away, that kind of thing, or with the cup and, you know. So that's basically my answer is that very often with the dementia, you also see psychological problems like depression, like maybe some obsessive compulsiveness, making sure they did something, maybe some paranoid feelings, etc.
Yeah.
Yeah.
Yeah, thank you. That kind of explains a lot too, because I know just before she left her work career, I
Hmm.
know she was having some problems, issues with her boss and stuff, and
Yeah.
I think that kind of put her in a certain state of depression, and it just kind of went from there to.
Before you're not diagnosed, and we'll get into this in talking about the mild Alzheimer's disease symptoms, being called in by your supervisor and being told that you're kind of, you didn't complete that thing, and didn't you remember that you were supposed to do so and so, that feels crappy.
Mhm.
That feels
Sure
terrible.
does.
You know, it's awful. So thanks for the comment and the question. That was good because it helps me expand. Anybody
Yeah.
else have comments, or and they could be about the clients you see, right, or whatever your experience is.
I just had a question, RoseMarie, about where the research is right now as far as developing, newer treatment models. I mean, I guess like, do you see like new medications on the horizon, or are they looking at other, like gene therapy or anything like that? Are they getting any closer, do you think, to maybe not necessarily a cure, but better treatment options to help slow down the progression?
Yeah, I I I don't think so right now. Let me just address medications. Those ads we see on television about this stuff you can take to increase your memory? Uh-uh.
Mm.
They really are. They there's nothing really on the market that significantly halts the progress of the disease. There really isn't. Okay. Now, what the interventions are that have some kind of small but positive outcomes are these alternative kinds of treatments in
Yes.
which people are put in a daycare program where there's music, where there's stimulation. You know, the literature talks about creating environmental press. And what that simply means is arousing the entire sensorium of the person in terms of smell, in terms of vision, in terms of interaction with others, and getting the neuronal networks that do exist, that are functional, to really be stimulated again. That seems to be something that, you know, there's work on right now, as you guys are doing, you know, with the equine assisted interventions. The other thing I wanted to say, when you asked just about the research, the big research, you know, is on, well, like, what the heck is it with these proteins that accumulate and form these clumps that literally shove out the neurons and kill them off? Like, what is that? And in the different kinds of brain disorders, it's different proteins. So therefore you have the Lewy body, you have the frontotemporal, you have the Alzheimer's with those amyloid plaques. It's the biochemical, the neurochemical research that really is the nitty gritty. And that's where it's going to be, because eventually then there would be a chemical application to the dissolving of those plaques, right? To their not forming, to the exploring genetic precursors for why they do form. Why do they accumulate in some people and not in others? You know? So yeah, that's where it is. That's where it is. All right, so let me just move on a little bit and to the next page, and that's really, I mean, I know I've told you a good chunk of information, but the good part comes when you, the good part comes when you describe your clients, you know. So here's where we can start applying things to what you do with them. So here are the signs and symptoms of Alzheimer's disease, okay? So very different, and maybe when you go home, if you're able to, I guess you're able to copy this, take a look at that initial list of normal aging. Very different, very different. So for mild Alzheimer's, and this is where you'll recognize some of your clients here, you know, there'll be forgetfulness, all right? More than just a little bit. Word finding difficulty, where person will be engaged in perfectly okay conversation with you and all of a sudden forget to, what is that called? It's a saddle. You know, what have I been riding every week? A saddle, on a saddle. They'll forget that word. Apathy, a kind of like a flatness, you know. I'm sure that sometimes you'll see your clients and they'll be up and animated, and other times there's a kind of like where are they? All right. Poor attention is another thing that's connected to that. Can't concentrate, can't focus. Difficulty with complex tasks, you know, telling a person, go down the hall and make a right, and then you'll find the bathroom on the left. And when you do, you need to jiggle the lock a couple of times before the door opens, okay? That's difficult. As I mentioned before, depression, you will see depression that accompanies mild Alzheimer's disease. And then there's work trouble, you know, which we talked about a little bit. Not able to finish their tasks, and then sort of psychologically reacting to being told, you know, being afraid, being ashamed. You know, there's shame here. Just because a person has brain disease doesn't mean that they don't feel all of those kinds of things that, you know, we're feeling right now. The apathy doesn't go that far, you know. All right, what about moderate Alzheimer's disease? And this is where you start to see some pretty scary things. Okay, so there's an increase in memory loss, but there's disorientation, you know, like, wait, how did I get here? you know, this is King Soopers. All right, we were going to go shopping. You know, this kind of disorientation, maybe having gone from a movie to shopping and saying, like, wait, where are we and how did we get here? That's pretty scary stuff. Confusion connected to that. You know, insomnia is a big one. Wandering. I don't know if you've ever had folks, relatives. There's a wandering, a kind of not knowing where they are. It kind of goes with the disorientation. This can be quite a difficult symptom in the sense that sometimes wandering can take place at night, wandering through the household, getting up to go to the bathroom, and then going into the kitchen, maybe lighting it up to warm some coffee. You see where this is going. This is dangerous. Also out of the house. How many times have we seen in the paper, you know, a person who's found wandering in their nightgown, you know? Very, very hard to manage. There's speech difficulty because of what's called, okay, word forgetting, but because of what's called, and I guess I should have put it in here, something called agnosia. It's in the severe column, but it can happen in a milder way in moderate Alzheimer's. Agnosia is not knowing the name of an object, like forgetting that this is a laptop, forgetting that that's a clock. Like, what is that? Not knowing words anymore, not recognizing and being able to use them. Restlessness sometimes goes with the wandering. In fact, the restlessness develops into wandering sometimes, a kind of an antsiness, you know. And there's a difficulty with activities of instrumental daily living, how to make coffee in the coffee pot, all right? How to turn on the switch for the compactor or whatever. Just forgetting how to do series of activities that in fact have been done every single day for decades and decades. Forgetting the sequence, okay? So these are activities of instrumental daily living. Okay, so agnosia. In the severe Alzheimer's disease, this is where you are also getting some real physical symptoms in which there's incontinence, a lot of difficulty walking, agitation and aggression. Now that borders into the psychological side, and sometimes there are let's say psychiatric medications that are used to treat those things, that agitation. I mean, we're not talking wandering and restlessness. We're talking thrashing, okay? Throwing things, bumping into things, etc. People can't take care of themselves anymore, so they need to be washed. They need to be fed. And needing to be fed may come from earlier on, maybe last year, when they forgot how to use a fork because dinner was in front of them and maybe they ate in a regular way and the fork is there and the aide may come and say, come on, like, have your meal now. Well, how do I do that? And when you get down to it, it's forgetting that the fork is, or the spoon is for scooping up and putting it into your mouth. So you have the person forgetting how to use the instrument, but also forgetting the sequence of activities of scooping up, bringing up, and putting it into the mouth and chewing. That's the extreme that it can go to. What else? Gait disturbance, which is the motor functions just don't work. Now, these people with severe Alzheimer's are not people that you're going to see in your program. It would be dangerous to have them, but maybe, you tell me, I don't know, maybe just being in the presence of an equine might be something. Apraxia, I operationally defined it. Apraxia is not being able to make and use the coffee pot, not being able to know how to use the spoon, all right? This is not a good situation because the cardiovascular system is compromised, because breathing is compromised, and because a swallow could be a choking and could be just choking and not making it. So this is a bad end. This is a bad end. But coming back, and this is the end of the concrete things that I wanted to share with you. I want to hear what your comments and questions are. And most importantly, what I want to hear is, how do these categories, I guess especially the mild into the moderate, tell me your experiences with your clients and how these manifest in your equine assisted situations. Do you see the forgetfulness? Do you see the poor attention or the difficulty in combining tasks? In tacking, you know, a horse and working with the horse? What are some of your experiences?
I'll start
Yeah.
a little bit. We use speech so much, and I think I'd like to hear from you and other people. What are some other ways to communicate when people have trouble with speech? We tend to focus on that, but I've noticed, that, the simpler the better. But do you have any other suggestions?
When you say trouble with speech, what are you talking about exactly? What kind of trouble?
Well, I think we tend to ask a lot of questions. How are you today? What's going on? And I've noticed they tend to not have the speech to describe that. So the variety isn't there. Vocabulary is disappearing.
Okay. The peppery talk back and forth just doesn't happen. Yeah. Well, let me just say that we are a very verbal culture. And yeah, we're nervous, and we talk when we're nervous, I think that you're going in the right direction by considering using less words. There is a tremendous amount that all of us can communicate in a nonverbal way. And we all know that because we're close to horses. I'm assuming that most of us, are involved with horses in some way. And you know how much we can tell by not talking to it. We can't talk to the horse, and how much we communicate with our bodies. I don't know. When you are a side rider with your clients, are you allowed, how much are you allowed to touch them once they're on the horse and pat them and maybe push them forward a little or push them back? How much are you allowed to be physically involved with them?
You mean with the client or with the horse?
Oh, sorry, with the client.
Yeah, they're very well when it's not COVID times.
Yes, I know.
Volunteers are usually doing an arm over thigh hold or a heel hold.
Okay.
Sometimes they're not.
Yeah.
Sometimes they're just walking alongside. Rich can answer that better.
Well, yeah, well, like with Peggy, she needs a lot of assistance just to stay up there when she's in motion. But funny thing is, when we stop, she's sitting straight up, holding onto the surcingle and beautiful posture. But because she's also got the issues with orthopedic, she needs a lot of assistance on both sides to just stay up there. But,
Okay. So there is a lot of physicality, obviously. There's
Yeah.
a lot of physicality. Why don't you try cutting out the verbal and increasing the physicality within appropriate range, Maybe a hand on the torso in the back, maybe a squeeze, you're doing great. Maybe eye-to-eye contact in which there's a smile, a warmth, like, yeah, with less words. I mean, we're constantly, I'm not saying not to say you're doing great, but to use more nonverbal cues. than maybe we're used to. Look, I guess every person is different, and I mean, when I get nervous, I'm chatty Cathy, and sometimes I just have to kind of calm myself down and connect more in a nonverbal way. So maybe try that. But people are overwhelmed with words. There's no question about it. And you need to tune in on every client to see how much your words your words are potentially drowning them.
Hey, RoseMarie, can I just add something there though?
Yeah.
I know, like when you ask a person with dementia a question, it kind of confuses them because they don't know how to respond. But sometimes instead of using a question, you might say something like, "Oh, your horse looks beautiful today, right?" And, something like that, where you kind of give them a little more of an idea what you're trying to ask them. And then I find, like with Peggy, that gets a better response because, yeah, a question I think is just very hard for some dementia sufferers to process.
Yeah, one thing I've noticed at work too, when I work as a dietitian in long-term care, when I'm interviewing clients, giving them more time to process.
Right.
Oftentimes they can actually communicate a lot more than you would expect if you just take a beat and let them have their chance to think about what you're asking and formulate their response. It just takes them a little longer, but they can do it.
Right.
Okay.
And I would agree with Rich too, is, keeping the questions more, if possible, to yes, no answers versus a complex response that you need, and also the whole learning the body language is a huge, it's like how we learn the body language of the horses and understanding what they're communicating. It's the same way with someone who's nonverbal. Is you can definitely learn from their facial expressions and body reactions what they're trying to communicate. It just takes time and it takes practice,
It does.
Yeah.
experience.
Let me ask you guys something. What would you say, how compromised are your clients? What would you say are some of the most compromised? Don't have language, are very confused, or maybe, I guess I want to picture what the average client is like.
Well, I mean, I would say, and I would say that we serve, we probably have served people with dementia in all three categories, but we've had quite a few in that moderate and severe category. We really
Yeah.
have.
And what do you do with the ones who are severe? Okay, so they're brought to the center. All right, they come into what do you do with them? How do you work with them?
Well, I mean, we will put them on the back of a horse. We have a ramp so that we can make it easier for them to get on the horse. We also have a mechanical lift. So if they're not able to do it themselves, we can actually lift them using that to get them on the back of the horse. We tend to keep the lessons a little bit shorter because they tend not to tolerate a full 60-minute class. They usually can go, anywhere from 20 to 40 minutes, depending on the individual. But, we keep the classes small, we keep them upbeat, we keep them active, engaging, even if it's just the volunteers that are engaging with the instructor and trying to get the rider to engage, but just keeping things stimulating for the rider. We've had instructors that use music in the lesson. So, all of that can get, can be part of the lesson plan.
Okay.
We have primarily use the indoor arena so that it is, but it's a nice big open space. So there's lots of, like you were mentioning at the banner, there's lots of sensory stimulation, smell, touch, taste,
Yes.
all of that.
Yes. So I want to tell you, and maybe you can kind of make a response to the science, okay? One of the last studies showed that not only were patients more enlivened, more lively within the activity session itself and the waiting at the benches and stuff like that. But the thing that seemed to last when they got back home for a while, okay, was, and this was measured, increased conversation, increased verbal for them, and increased expressions of pleasure. I mean, those were the two things that showed a bit of lasting effect. And I was wondering whether any of you could pinpoint the stuff that you do that would have made that happen.
Well, so I'm going to speak to that, and I'm a physical therapist, RoseMarie,
Okay.
and so
Okay.
I'm looking at it from strictly from a motor standpoint.
Yeah.
The movement of the horse provides so much neurostimulation in every beat of every step that horse takes. It is stimulating the sensory and the neurological system of every step that horse takes. So, my guess is that it's activating. So it's activating to the neurological system. So I think it's just overall, I think it's the movement of the horse. I think all of it. I think the movement, the smells, the sounds, I don't think you can tease out just one particular thing.
Yes. Yes.
But I think primarily if they do further research, they're probably going to find that it's the actual movement of the horse.
Interesting. Yes. And I was thinking of another thing, and in a way we're playing with theories. How is it working? So we're seeing that it's working. How is it that it's working? So I was thinking, because one of the outcomes was an increase in expressions of pleasure. Okay. In other words, they look happier. Okay. Is that what's being addressed is depression and the shut-in way of living inside their disease and inside a facility and outside of their regular lives. So I wonder if what's being treated is a certain isolation, a depression. They're saying, my life stinks. So maybe that's a very basic thing, and I was mentioning, I wanted to get to this, and Rich, you were talking about this with, I think your wife, and, so it seems funny, but people are evaluated for depression when they have dementia. And sometimes treating that depression will all of a sudden make the cognition better, less confused. So that some of those confused symptoms were coming from the affective component. They call it the affective disorder. And that is something to become aware of. I think that we still have some pretty negative attitudes about people with Alzheimer's. I think that to us, we still, in our minds, are kind of using that old wastebasket, thing. Oh, the person's just senile, can't do a thing. I think that more attention needs to be paid to the emotional side. Very much to the emotional side, which certainly going out to a place where there's a bunch of horses really does. So, yeah.
Yeah, well,
RoseMarie, I have two thoughts. Or go ahead, Rich.
Oh, well, I was just going to say to your last point, RoseMarie, that is very much true. Like in my situation, and I try to get Peggy out as much as possible for the social. I don't want her to feel like she's got to be locked in. So that's been kind of my mission, just to keep her socially active. And, the depression part of it just disappears when she's like at Hearts and Horses, or if I take her shopping, things like that. Get her out to the parks on days like this. So to me, that seems to work very well for her.
Well, you are a loving clearly a loving and engaged partner but you can imagine those who aren't as fortunate as
I do.
Peggy is, you know, who are in facilities
Yeah.
because their family is sparse or not present. And, you know, if what we're talking about is that 50% of beds in nursing homes, all right, are occupied by people who are this compromised, you're talking about a tremendous amount of staff that's going to be necessary to do that stimulation.
Absolutely.
Okay? You're doing a smidge, you folks. I mean, there needs to be gazillions of you, you know, and, you know, and the creativity to do the stimulating in many, many other ways, you know. So, wow. So let me see, what else can I share with you? What else can I answer for you? I don't know how far we're going. It's a bit after 6, so. Oh, okay, there are references here. And, you know, you could look them up. They're all the sort of technical articles. And I don't know, Emmy has my number. You can call me if there's a question. And if I don't know it, I'll find out about it.
And I will be posting a recording of this lecture series on the website sometime next week. And I can also, if it's all right with you, RoseMarie, I can email this Word document out to everyone who attended today as well.
Absolutely. Please, please do. That's why I did it.
Okay.
You know, I realized when I did this, man, this looks so boring. I should have done a really pretty PowerPoint thing. Maybe next time.
It has all the info, and that's what matters.
That's the
Yeah,
info.
your content was great.
Okay, I'm glad. And I don't know, if you want to hear something more, just let me know. And I live in Longmont, and I'll get myself up to Hearts and Horses and hopefully be able to get into some of the training that you do. So thank you for having me.
Yeah, thanks for being here.
Okay.
Thank you.
All right.
Thank you.